Good afternoon. I'm Professor Daniel Prieto-Alhambra. I'm a professor of pharmacoepidemiology at the University of Oxford at the Center for Statistics in Medicine. And I am delighted to be presenting to you today the work that we have been doing with colleagues from all over the world, but including the generous collaboration from colleagues at HERA and in South Korea in general in the response to the COVID-19 pandemic. And I'm going to be focusing on the lessons we have learned from Odyssey and Eden for the global, speedy and reliable research of drug safety during this pandemic. This is the three topics that I'm going to be covering. I will start by explaining very, very shortly what Eden and Odyssey are. I will then cover how we work with Odyssey and Eden and how we did that during this pandemic in particular to maximize the reproducibility and speed of the research that we do through international collaboration. And finally, I will cover the rise and fall of hydroxychloroquine. And I hope this will be an enjoyable talk for you for the next 20 to 25 minutes. Okay. Odyssey is an open science community. It's an international, global, and multidisciplinary collaboration, which includes people from different stakeholders, all the way from academia, FPR, drug industry, vaccine industry, regulators, government, payers, and all sorts of disciplines you can imagine, going all the way from engineering, computer sciences, epidemiology, statistics, biomedical informatics, and clinical sciences. The Odyssey community engages regularly in a number of ways, the most popular one being the Odyssey forums, where there are more than 3,800 registered users with thousands of posts on thousands of topics, including a number of fora within this forum: implementers, developers, researchers, CDM builders, vocabulary users. And there's interestingly, an Odyssey in Korea research group, which I encourage you to visit. There are weekly community web conferences for all collaborators to share their research ideas and their progress with their work. And we have both a Eastern friendly timetable as well as a Western friendly one. The community engages on top of the forums during tutorials on the Odyssey tools and best practices for real-world research. And in the pre-COVID world, we used to have face-to-face meetings in North America, Europe, and Asia, at least once a year in each of those three locations. This year, as you'll see in a second, we had to cancel the European Symposium that I was due to host in Oxford, and we're going to have a global symposium from October 18th to 22nd, which again, I would recommend you attend if you're interested in this field. You can follow Odyssey in Twitter at Odyssey, and there's also a LinkedIn account you might be interested in. The idea behind Odyssey is the use of a common data model to enable standardized analytics. The idea is that one can get hold of clinical data coming from different sources. Here you have three examples: electronic health records, which are very common in Europe; administrative claims, which are very common in Korea, I think, and also in America, in North America; and then clinical data that can come from many other sources, usually less granular and more granular and smaller. All these data sets, all these three examples, can be then mapped to a common data model. Here we are using the OMOP common data model. And after that transformation, all three databases look exactly the same in terms of structure. That then enables us to conduct federated analysis, where we can share our packages for analysis, and these can be run on top of the common data model. And one research can actually run code and test it in their own local mapped data that's already on the CDM, and then share that code with colleagues from all over the globe for them to run that same analysis in their data, just sharing results and never sharing patient-level data. This then has to result, and this is one of our commitments, in the distribution and dissemination of open, reliable, and robust clinical evidence. There are three things we do with real-world data in Odyssey and probably in any other similar collaboration. One is looking at characterizing people. This is basically observing a group of people and looking at what happens to them. The second thing we do often is patient-level prediction, as we call it, which basically aims to produce prediction or tools or algorithms that allow us to predict who will have a given event or a given outcome. And finally, and this is what's going to be the focus of most of my talk, we do population-level effect estimation, which aims to characterize the causal effects of a particular intervention or health technology, usually a medicine. We have an agenda, a very strong agenda for full transparency in all the research we do. We share all our artifacts and analytics pipeline. We share all the documentation of the ETL, of the mapping to the common data model. We share our data quality dashboards, where we share the quality of the data that we have utilized for the analysis. We have registered, or at least openly available, protocols before we conduct any research. We share standardized packages for analysis. We share all our study diagnostics so that people can realize the robustness of our analytics. And we do share, as you will see during today, all our results in a fully reported manner in an interactive web. Doing all this, what we aim to do is increase the reproducibility, interpretability, and trustworthiness of our findings. In the COVID-19 pandemic, we rallied together to collaborate with colleagues from all over the world, and we managed to have access to 8 colleagues, 8 groups of collaborators from the United States, which gave us access to data from a number of data sources, mostly hospital electronic medical records, and also a massive data set of open claims called IQVIA Open Claims that you can see there, and the Department of Veterans Affairs, which is a very useful national resource. In Europe, we collated data from 7 data sources, including mostly primary care electronic medical records, but also ambulatory records and hospital EMR. And from Asia, as you probably know, we had access to data from South Korea very early on in the pandemic. Actually, South Korea was one of the countries that led the way at the beginning of this pandemic in terms of driving our research agenda. And we have recently also engaged with a group of hospitals in China. This together meant accessing more than 4.5 million patients tested for SARS-CoV-2, more than 1.2 million patients diagnosed or tested positive for COVID-19, and almost 250,000 patients admitted to hospital for COVID-19. EDEN is a European funded project which aims to basically generate an ecosystem for multinational research using the common data model and extending the work done by Odyssey in terms of analytics. In April, EDEN decided to launch a call to any institution in Europe holding useful data on COVID-19. We had 75 applicants and we gave 25 grants. And we are now, as we speak, mapping all this data to the common data model, and we will have access to all of this in the future. Some of this data has already been analyzed, including the CDA, Spanish electronic medical records, including more than 120,000 cases of COVID-19. Okay, so now that you know a bit more about what Odyssey and Eden are, I'm going to now cover the methods and the efforts that we've put together to maximize reproducibility and speed through our international collaboration. Oxford, the place where I work, is not necessarily a very an institution that's driven the agenda for speedy research in the past, although we have, I believe, shown to the world that we can do really quick trials with the recovery study that you've probably heard of and the ongoing trial for the Oxford vaccine. And we're also very engaged with this community of Odyssey and Eden to drive and help with the speedy research of drug safety and prediction and characterization. So we hosted this COVID-19 International Study-a-thon with other colleagues from around the world from March 26th to 29th. The original plan was actually to have a nice meeting in Oxford. I had already booked a very nice venue in the city centre. We had more than 200 people registered at the time we cancelled, and the plan was to host over 300 to 300 people with a lot of science, a lot of talking, and a lot of learning, and hopefully some fun and some face-to-face and personal collaboration. We had then to cancel this meeting, unfortunately, due to the uprising number of cases of COVID-19 around the world. And we then decided to explore how we could help the response to this pandemic. We did three things that are very tied together with what I discussed earlier. We looked at phenotyping, prognosis, and care needs of people with COVID-19, which would fall under the space under the umbrella of what we call characterization. We looked at prediction, trying to assess who would be at high risk of severe forms of COVID-19. And Professor Patrick Ryan will be covering these two topics later on in his talk. And probably more interesting for me as a pharmacoepidemiologist, we explored the opportunities and the needs for drug safety research in this field, which was an interesting one given the increasing use of medicines without real hard evidence for their use in the pandemic. You probably know that during the early days of the pandemic, there were emergency approvals for medicines like Temra, which is tocilizumab in China, and probably much more mediatic and a lot all over the news, we heard from Donald Trump about the promising or very encouraging results, as he put it, of hydroxychloroquine treating coronavirus. So our aim was to estimate what was the safety of the most commonly used repurposed therapies for COVID-19. And in early March, when we started planning this, we realized that hydroxychloroquine was indeed taking over pretty much a lot of the market in this space. And data from Spain told us that 70% of patients admitted to hospital were receiving hydroxychloroquine, and almost 1 in 3 were receiving a combination of hydroxychloroquine and azithromycin, which we knew could have some consequences, as both medicines can enlarge your QT waves in your heart and therefore produce potentially lethal arrhythmia. There was even some news from Andorra, a very small country between Spain and France, that decided that they would treat everyone in the whole country with hydroxychloroquine and azithromycin if the pandemic got out of control, because they believed that this would be an effective way to do basically primary prophylaxis against COVID-19. Luckily, this didn't happen in the end. So, by the end of our 4-day activity of this study-a-thon, we had more than 350 participants from 30 countries. We held 12 global huddles, as we call them, meetings in a virtual environment, in a Teams environment, more than 100 collaborator calls, thousands of messages, and we reviewed thousands of papers, drafted 9 study protocols, released study packages, designed lots of cohorts, and assembled a distributed data network with 37 partners who were keen to execute studies on the data. By the end of those 4 days, we had finalized these 3 activities that nobody had done before at that time. We had done the first large-scale deep phenotyping characterization of COVID-19 patients admitted to hospital in Europe, North America, and Asia. This is now published in Nature Communications in preprint in medRxiv. We completed a prediction model that had been internationally, externally validated to inform who was at high risk of having severe forms of this disease, called COVA. This tool is now again in a preprint and under review in a prestigious journal. And what I'm going to focus on for the rest of my talk, the largest study ever conducted on the safety of hydroxychloroquine. So how do we maximize reproducibility in drug safety research with Odyssey and Eden? This is a slide courtesy of Patrick Ryan and George Hitvrak, where you can see evidence from a previous literature review that there is a lot of p-hacking, a lot of evidence for p-hacking, lots of observational evidence, lots of observational studies showing a lot of clustering around the magic p-value threshold of below 0.05. I believe this is quite sad, and we have to do so much better. The attributes for reliability in any evidence really, but in particular in real-world evidence, are summarized here, and what we want to maximize is reproducibility, which is the second row, meaning that if one asks an identical question in identical data using the same analysis by 2 different researchers, you should get the same results. Although I believe we all would agree that this is something we desire and we should pursue, I'm pretty sure that we can all agree also that this is not something that we see very often. The way having a CDM helps is basically by helping us document and pre-specify and specify to the detail, to the last comma, every single step that goes from the patient level data to the generation of reliable evidence. Having the data in a common data model helps us basically split the journey in 2 segments. The data standardization segment, which is to the left of the plot, so from the red to the blue boxes, and the analytics. Okay, I'm now going to cover the results from our drug safety study looking at hydroxychloroquine. And I will start with this statement from the President of the United States, who said publicly, "If it's not good, I'll tell you right, but it's not going to hurt me." That's what he thought, at least, when he made this public statement. Of course, this study falls under the umbrella of what we call causal inference or population level effect estimation out of the 3 that I mentioned earlier. And this is the title of our study. Initially, it was going to be called Safety of Hydroxychloroquine Alone or in Combination with Azithromycin in Light of Rapid Widespread Use for COVID-19, a Multinational Network Cohort and Self-Control Case Series. In the end, we, after our findings, as you will see, changed safety for risks. This paper is now published, by the way, in Lancet Rheumatology. For all of you who are clinicians, we are told in medical school this Latin statement that says primum non nocere, which means first, do no harm. And I think this is quite against this statement made by Mr. Donald Trump. Hydroxychloroquine is indeed a cheap generic medicine. It's indicated for rheumatoid arthritis, lupus, and the prophylaxis of malaria. It's been around for over 40, 50 years, And we know it's relatively safe, but we also know of its toxicity in the eyes, and we also know that it can cause some cardiac issues. There was a lot of in vitro evidence that this drug could help against COVID-19, and a lot of publicity. Unfortunately, as we've heard and learned later on from the recovery trial, it seems like the medicine was actually not that effective in the end. And as we'll see in a second, it is not that safe either, especially when you take it in combination with azithromycin. Data from our characterization studies showed that hydroxychloroquine was indeed being used quite a lot in patients with COVID-19. Here you see on the x-axis the proportion of people admitted to hospital in different places who were prescribed hydroxychloroquine during that admission. You can see a lot of variability from Stanford to the left, with just about 1–2% of patients. This is Stanford, California. To the right-hand side, where you see data from hospitals in Spain, HM hospitals, where more than 80% of people were actually put on hydroxychloroquine, with a lot of variability in between. South Korea, the HERA database is somewhere around 25 to 30%. So with that in mind, given that this was a medicine that could be of potential public health interest given its wide use, we went and looked at retrospective data that we had available in March when we started planning this. And at that time, we managed to put together a cohort of more than 900,000 users of hydroxychloroquine who had been taking this drug for rheumatoid arthritis. And we were interested to learn on the serious adverse events of this medicine alone, and also the potential effects of adding in azithromycin in a cohort of people who were taking hydroxychloroquine. Because we didn't have any COVID data at the time, or very little data, we went and used data on patients with rheumatoid arthritis. We used data from Germany, Japan, Spain, South Korea, the US, and the UK. And we conducted a new user comparative cohort analysis. And on top of that, we also performed a self-control case series, which I'm not going to present today. Participants in this study were aged 18 plus and had to have at least 1 year of visibility in the data. And they had to have a diagnosis of rheumatoid arthritis, and of course, be new users of any of these medicines. We followed them for 30 days, which we believed was the most relevant analysis to the COVID-19 response, given that treatment with hydroxychloroquine in this condition is not chronic, but rather short-term. And we also did a non-treatment analysis, which is probably of less relevance here. This link here takes you to the full reporting of the results in an interactive website, but I'm just going to give you a quick overview of our findings in the following slides. We had data from all these databases from the US, the UK, Germany, and Spain. We ran the analysis also in the Japanese, Korean, and Spanish databases, but unfortunately there wasn't enough use of hydroxychloroquine to conduct the full analysis there. When we looked at the short-term safety events, we didn't find any increase in any risk for hydroxychloroquine when compared to sulfasalazine, which is an active comparator. It's a medicine that's used for a similar indication in rheumatoid arthritis. You can see here for each of the databases a dot and an interval, a confidence interval, and then for each of the outcomes you have a white triangle or shape that shows you the meta-analytic estimate. And you can see how this cardiovascular-related mortality is not increased, chest pain or angina is not increased, and heart failure is not increased. However, when we looked at now the comparison of in the cohort of people taking hydroxychloroquine, adding in azithromycin versus adding in amoxicillin, what we saw is a striking increase of more than double the risk of cardiovascular mortality, slight increase in the risk of angina, chest pain, and a significant relevant increase in the risk of over 20% in the risk of heart failure. We believe this is all related to QT lengthening and potentially lethal arrhythmia. In the long-term analysis, which I'm not going to cover in detail, it looked like the therapy, hydroxychloroquine, increases the risk of cardiovascular mortality by about 65% compared to sulfasalazine, with no other risks. This is a long list of all the other outcomes we looked at, including cardiovascular effects, venous thromboembolism, stroke, gastrointestinal bleeding, renal failure, and hepatic failure and pancreatitis. And as you can see here, we didn't see any signal for any of these safety events. So our findings led to the publication that I mentioned in Lancet Rheumatology. They also led to a regulatory warning from the EMA and the FDA, and it changed clinical guidelines internationally. We followed up with a more recent analysis of potentially concerning psychiatric disorders with this medicine, with hydroxychloroquine, after the EMA raised the question that there might be an issue there as well. And we didn't find in this case any increased risk of depression, suicidal ideation, or psychosis. On top of changing clinical practice, resulting in a nice paper and regulatory warnings that I mentioned, this paper and this work that we've done on COVID-19 drug safety has been mentioned by the methodological standards published by the European Medicines Agency in the most recent revision of the NSEP methodological guidelines. This is now finally the demonstration of the rise and fall of hydroxychloroquine, where you can see in a total of 4 databases how the medicine started increasing in use dramatically in February and March amongst patients with COVID-19, but then fell in May and in June after the publication of the recovery trial and after the dissemination of our findings. Thank you very much. I will stop there and I will be delighted to take questions in real time. Thank you.